Let her complete the
Just give me a
history.
question. If you would like to complete the history, wonderful. Please go ahead, Dr. Sahera.
Okay, okay. Let her complete the history.
She has completed history, sir. Past history she is going into. That's it.
Okay, okay. So on the history wise, Sahera, what is your provisional diagnosis?
No, any history of fever?
No, sir.
Hello?
No, sir. No history of fever.
No history of fever. Okay.
Can you, okay, okay. So, can you summarize the history?
Yes, sir. Sir, here is a 22-year-old female presenting with complaint of mass per abdomen since 15 months. That has gradually progressed in the last 6 months, and also complains of pain over the mass since last 2 months, and she no other significant history, sir.
Okay, okay. All are possible. Many diagnoses are possible. Can you move on to the examination?
No, past history, other parts.
Past history.
Yes, sir. Here is a young female, poorly built and moderately nourished, conscious oriented to time, place, and person. Pulse rate 88 beats per minute, BP 110/70 mmHg, saturation 99% at room air. Her BMI is 18.9. There is no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, and pedal edema. On systemic examination, abdomen, on inspection, a solitary vertically ovoid mass of about 17 cross 15 centimeter, noted in the left side of abdomen, occupying umbilical, epigastric, left hypochondriac, and left lumbar region. Umbilicus appears normal and shifted towards the right side of abdomen. Surface appears smooth with regular, well-defined borders, no visible pulsations. Skin over the mass appears stretched, no dilated veins or scars noted. The mass does not move with respiration. Cough impulse is absent. No visible peristalsis noted, and mass becomes more prominent on head raising. Sir, I have a video of head raising test, sir.
I think the video is not attached to this file, ma'am.
Okay, yes, sir. Proceed, sir.
No problem about that. If it is not, we'll go ahead with that. Okay, please go ahead.
Yeah.
Yes, sir. Rest of the abdomen appears flat. Corresponding quadrants move equally with respiration. No flank fullness. No other mass noted over the abdomen. Hernial orifice is intact. External genitalia normal on inspection. Palpation. No local rise of temperature. No tenderness. A solitary vertically ovoid mass of 17 cross 15 centimeter, noted in left side of abdomen, occupying umbilical, epigastric, left hypochondriac, and lumbar region, and left lumbar region. Overlying skin is pinchable. Surface is smooth with round and regular borders, and mass is uniformly firm to hard in consistency. Mobile in transverse plane with minimal mobility in vertical plane. On head raising, mass becomes immobile in both transverse and vertical plane. No other mass palpable in other quadrants of abdomen. No organomegaly. External genitalia normal. On percussion, dull note over mass, tympanic note over rest of the abdomen. No evidence of free fluid. On auscultation, no bruit. Normal bowl sounds heard over rest of the abdomen. Other systems, respiratory system, bilateral normal vesicular breath sounds heard. Musculoskeletal system is normal on examination. Cardiovascular system, S1, S2 heard. Central nervous system, conscious and oriented.
Yeah.
Hello.
Yes, sir.
Hello.
Can you give the provisional diagnosis? Have you finished the examination?
Yes, sir.
What is the plane of the mass?
Sir, On examination, it appears to be extraperitoneal, sir.
Extraperitoneal.
Yes, sir.
Uh-huh. How did you come to this conclusion?
Sir, first on palpation, sir, the mobility of the swelling is more transversely and less vertically. Then on head raising test to make the underlying muscles taut, the mass becomes immobile, sir.
Mass becomes immobile.
Yes, sir.
See, doctor, you can use a word like extraperitoneal in provisional diagnosis.
No, is it from the muscle or superficial to muscle or deep to muscle?
No, it
Must
should be
be
like, I think, parietal, intra-abdominal.
Parietal mass or
Parietal
intra-abdominal?
swelling?
Yes.
No, what is
In
the
the
plane of the muscle?
anti-abdominal
What is
wall.
the plane of the swelling?
Is it subcutaneous?
No, sir.
How do you say it is not subcutaneous? What are the findings to say it is not subcutaneous?
Sir, on palpation, the mass appears to be fixed to the underlying muscle, sir. Because on making the muscle taut, the mass becomes immobile, sir. If it was subcutaneous, it would be mobile, sir.
Okay. So
Is the
rising from
swelling
the
becoming
muscle
more
or
prominent? Is the swelling becoming more prominent on putting the muscle into contraction?
Yes, sir.
so it is
What are the
fixed.
other tests you should do when there is a flank swelling? One is head raising, leg raising, and another one is Valsalva maneuver. Valsalva maneuver.
Yes.
You have done head raising test or leg raising test or Valsalva maneuver?
Head raising and leg raising.
Okay, you have put the muscle into contraction and the inference is it is restricted in mobility.
Yes, sir.
Huh? Okay?
Yes, sir. Yes, sir.
Okay. So what is your differential diagnosis? Any differential diagnosis?
Sir, can I ask some questions, sir? Yes,
Yeah,
Dr. Rajgopal.
please.
Dr. Sahera, just go to the general physical examination slide, please. General
sir.
physical exam. Just because since it is we have some time there, we'll just analyze this few things. Yeah. So I just
Yes.
want to ask you a few important questions related to your patient. Okay. Because
Yes, sir.
in the history wise, one or two things I wanted to bring the attention here. Very fact that patient notices a lemon-sized mass. Your topic is abdominal mass, absolutely fine. So what does it tell you? Do you think any patient with the intra-abdominal masses can tell you that it was like a small lemon size? Or what is the inference of that first statement?
So since we can tell the size of the swelling, it is probably just below the skin, sir, not intra-abdominal, we can say.
So no, don't say below the skin. So what you are trying to do is deeper to the skin. Okay, number one.
Yes.
Okay.
Yes.
So secondly, we started with the left side of the abdomen, correct? You started with the left side of the abdomen, correct? Yes.
Sir.
So obviously the jaundice, all that which you have written in the initial part probably may not have the relevance. Okay. Now come back to this general examination slide. So forget about for the time being the abdominal wall swelling. Forget about that. What is the inference of knowing about the lymphadenopathy and pedal edema? Just one or two random questions.
So lymphadenopathy, to look for any lymph node enlargement, sir, axillary or inguinal, sir. Since
So
the mass is in the anterior or abdominal walls.
So since the mass in the abdominal wall, or we'll put it like this, we'll say it is on the left side of the abdomen. At that stage, you did not know whether it's intra-abdominal or abdominal wall. You understand, no? So keeping those things in the mind, we would like to have a generalized lymphadenopathy, whether it's a tuberculosis, lymphoma, then pedal edema, all these things related to nutritional, etc. Just quickly show me the inspection slide. Inspection. Yeah.
Yes, sir.
So that's all fine. So here, the important thing is that umbilicus, you have written that appears normal, actually slightly deviated also. And surface smooth, regular, well-defined borders, no visible pulsations, right?
Yes, sir.
You have written that, no? Correct. So what is the
Yes.
importance of knowing the pulsations at this area? May not be in your patient, but generally.
Sir, abdominal mass pulsations, we usually ask
Hmm.
for vascular swelling, sir, like abdominal aortic aneurysms
So,
or
so
angiosarcomas.
obviously it's more in the upper abdomen, above the umbilicus. What is the importance
Yes.
of knowing this? Dilated veins. In your case,
Dilate
particularly. Yes, tell me. Yes.
the growth, sir. If the mass is rapidly growing and there is excess growth, overlying vessels get dilated.
Just in the correlating your clinical scenario of your case, maybe a high-grade sarcoma. You understand, no? High-grade
Yes.
sarcoma. Those are the veins which may have a dilated vein, especially more anteriorly. Next slide, palpation or something, palpation. Just, yeah. Yeah, that's, yeah, just keep that slide. Sorry. Yeah.
Next.
Most of the things she has done well, sir, because she has told the skin, then surface, then consistency, mobility, and head raising she has done. Everything is, that's fine, sir. All the thing. My only one thing is about external genitalia, that too in a female. You understand, no?
Yes, sir.
What's the importance that in a male patient, if this were to be the male patient, you understand, no?
Yes, sir.
Yes.
Sir, in male patients, I would examine testes, sir. Usually, testicular carcinomas present with pre-aortic or para-aortic lymph node
Very good. Very
enlargement.
good answer. So it is the relevance of that is
Primary.
particularly in a female, in a male. Okay, external genital. No problem. Sir, examiners can take us, sir. Diagnosis differential, please. Sir.
Yeah, differential diagnosis, please. Desmite
Yes.
acceptable. We'll discuss later. Differential diagnosis. Do you have any?
Sir, rectus sheath hematoma, sir.
Rectus sheath
Or,
hematoma. So long. Progressive.
or soft tissue sarcomas of abdominal walls.
Yeah.
And
Soft
rectus
tissue
sheath
sarcoma.
is too medium. This swelling is too lateral for rectus sheath hematoma. Rectus sheath hematoma also occurs infraumbilical.
Yes.
The period is too long and it is progressive. Okay. Soft tissue sarcoma probably another differential diagnosis. That is, so how do you differentiate between soft tissue sarcomas and desmoid tumor? Do you have any points?
Soft tissue sarcomas usually will be rapid growing, sir, with
Okay.
complaints of
It is
complaints of
it is grown from a small lemon size to cricket ball over 6 months. It is fairly rapid.
yes, sir.
So how do you refute this sarcoma, or are you keeping it as a differential diagnosis?
And
Patient
desmoid
also
tumor,
says
what is the
that
common location for desmoid tumor?
extremities, sir.
Huh?
Extremities.
No.
Hey,
Desmoid
desmoid.
tumor in the
Or
anter-abdominal
desmoid.
wall, what is the common location?
Umbilical patient.
Is desmoid tumor common in anterior abdominal wall? Otherwise,
Yes. No, sir. Retroperitoneal.
no, it is common. No,
Desmoid
anterior
tumor
abdominal
is
wall.
not retroperitoneal.
It is anterior abdominal only. You are right, but you should answer. So desmoid tumors are more common in anterior abdominal wall, extremities also. So soft tissue sarcoma is another differential diagnosis. You should have put the soft tissue sarcoma also.
Yes.
Okay. Any other differential diagnosis?
Soft tissue sarcoma is common in anterior abdominal wall.
No, sir.
You should tell, discuss in that way. Why you are not saying, and what is the consistency of the swelling in sarcoma?
Be firm, sir. Firm to hard.
For
To hard.
sarcomas,
The soft tissue sarcomas can occur anywhere in the body. Anterior abdominal wall is not immune to that,
common, sir.
and it is firm to hard. That is acceptable. What do you say, sir?
Variable in consistency, always variable in consistency. Sarcomas are known for that. Your
Yes,
tumor is, your swelling is, what is the consistency?
Firm to hard, sir.
Then
No,
it's
you told it
variable.
is
You
hard.
don't tell like that. See,
Variable.
when there is a different way, different place, different concept, you should tell variable in consistency. That is the safest word to use, rather than firm to hard. Then they will ask you what is variable. Then you tell somewhere it is soft, somewhere it is hard. Finish.
Yes, sir.
You said
Sir,
it is uniformly
sir,
firm to hard. Okay.
shall I come in, sir? I just don't want to waste
Please.
some time. There are a few questions here, sir. Dr. Sahera, is there any chance that it is intramuscular lipoma?
Could be liposarcoma.
Is there any chance
Yes.
can it be an intramuscular lipoma?
Yes, sir.
Okay. Okay. Why do you think so? It can be a lipoma.
It is hard, no?
It is
can-
hard one thing. One sir.
Oh.
It is hard one thing. You on contraction, what is happening to this tumor here?
Yes, sir. It becomes immobile, sir, on contraction.
It becomes more prominent. More prominent means where is the tumor here?
Within the muscle, intramuscular, sir.
Intramuscular or over the surface of the muscle or just
Point is,
attached to the muscle?
Guru, can I intervene?
Yes, sir.
Hello, Sahera. So your point
Yes, sir.
to say against intramuscular lipoma is it is hard in consistency.
One.
Okay.
Next is, if it is intramuscular, what would happen to the on contraction?
And contraction, it still becomes prominent or less prominent or depending upon
It will
the.
be firm rather than hard. It will be firm.
Yeah.
It will be less prominent.
Yes.
The swelling has to be become less
Intramuscular, it
prominent.
becomes less prominent. If it is attached to the muscle, it becomes more prominent. These are the two things here. Then what do you say?
Sir, I think we'll proceed, sir. I think Dr. Sahera, what they are
Yes, sir.
trying to say that you have mentioned that it is hard, firm to hard. So hold on to that and try to explain something like a desmoid. Yes, definitely, because you have worked out the case in the examination, in the university exam. Obviously, they will ask you these questions so that you know how to defend your case. Like, so anything which is hard, obviously fibrous element is more, correct, no? So like
Yes, sir.
even in the swellings elsewhere, we say, no, neurofibroma, there's fibrous transverse mobility in the direction of nerve if it is there. So that's how you say. Fibromatosis, desmoid, these are the few things which should come into the mind. So, okay, I think we can proceed now. And any Dr. Shivaprasad, you have any questions for the candidate to ask?
I want to ask what is
Yes.
the common site for desmoid tumor in the anterabdominal wall?
Okay, sir, please give the answers so that we can continue. Yes.
Dr. Sahera?
Rectus, sir.
It is above umbilicus or below umbilicus?
That's all.
Mm.
Supraumbilical or infraumbilical?
Below
First.
umbilicus.
Huh?
Right, sir.
Below umbilicus, sir.
It is below umbilicus.
Yes.
Okay.
I think.
Okay. So how do you confirm the diagnosis? You have desmoid and soft tissue sarcoma. How do you confirm the diagnosis? How do you proceed next?
Sir, I would like to do certain imaging investigations, sir, like ultrasound abdomen or chest, erect X-ray abdomen, sir.
Ultrasound, how does it help you?
Sir, in ultrasound, we can rule out the other diagnosis if we have, and also we can know the extent or
What other
till where
diagnosis?
we can
Like
rule out if we are considering any calcified cysts, sir.
calcified cyst. Okay, you have not kept it as a differential diagnosis. Why do you bring it new one?
Yes. And
I
we
asked
can
you the
also do
differential diagnosis.
yes.
Calcified cyst, will it be helpful by the USG? If it is calcified?
No, sir. Erect X-ray would be.
Okay. A plain X-ray may throw more light. Apart from that, any other reasons for USG?
We can know about the plane of the swelling.
Yes, okay. Plane of the swelling, okay.
Then if it is involving any surrounding vital structures.
Vital, which vital structure?
Anterior abdominal wall, what vital structures are there? Anterior abdominal wall, what are the vital structures? If it is in the posterior abdominal, if it is in the retroperitoneum, then you will have a lot of vital structures.
So, intention of you ordering the ultrasonography is one, to know the plane of the swelling. Next, what is happening with your consistency based on the ultrasound.
Whether it is solid or cystic.
That's it. These are the two things which will give you, is there any relation to the major vessels or vascularity, all those things that would help you. So you should know what is your intention whenever you order an investigation. This is it. You say USG abdomen, it becomes wrong. You say ultrasonography for the swelling, yes, you are right, because it is anti-abdominal. What is that you want to know in the inside the abdomen? Right?
Yes.
So if it is a solid cystic or not, that will also again helps you, minimally invasive investigations like fine needle aspiration cytology, all those things. Then before this, you need to complete routine investigations, so that to order invasive investigation to something like bleeding disorders, all has to be ruled out here. Because you also had such. Yes, sir.
Here, you should investigate in the first confirmation of the diagnosis. The provisional diagnosis is desmoid and differential diagnosis soft tissue sarcoma. So non-invasive investigations like other non-invasive like CT or MRI will definitely have more weightage than your USG.
Yes, sir.
Yes, sir. MRI will be more specific and sensitive in anterior abdominal wall tumors.
Yes, sir.
Am I right? So do you want to do any confirmatory investigations?
No, you have to first establish the pathology, no? To establish pathology, what is the thing is essential?
Biopsy is essential.
What kind of biopsy?
No, before going that, we can ask her what is the ultrasound report now in this case.
Have you done the ultrasonography report?
Yes, sir.
Yes,
No,
sir,
what
it
is
has
that?
been
You
done.
read out?
No, it's okay, sir. I'll tell you, because the shortage of time is there. I just want this thing. The ultrasound abdomen is anterior abdominal wall tumor, probably desmoid.
So now, how do you confirm your diagnosis? Next step.
Sir, I would proceed with invasive investigations like core needle Prukat biopsies.
Before
Why not
Prukat, can you do FNAC?
FNAC by itself alone will not be much of help, sir, to know because the
One minute,
of a bigger
Sahera.
size.
One minute. After ultrasound, you got that it is a desmoid. You would like to have another investigation of radiological investigation?
MRI, sir.
Yes, you
Then-
tell that. Why you want to do
Yes.
MRI?
MRI will give a better resolution of the plane of the soft tissue involved.
Exactly. Then you go for a invasive.
So,
Yes, sir.
sir, I just want to come here. FNAC, do you would like to do FNAC or not? Of course, true cut biopsy before MRI, I will not accept. Do you like to do FNAC or not?
FNAC will give us only the
Yes,
type of
cellular
yes,
cytology it will give, whether it gives what? Is it a real spindle cell tumor, epithelial tumor, or any round cell tumor, all those things. Because this is a soft
sir.
tissue tumor. Probably this is in abdomen. You are thinking in terms of desmoid. Sir's question was earlier was very relevant. Is it infraumbilical or supraumbilical? That will tell you this can be desmoid. We don't say deny it, but it is supraumbilical. We should also have a thought that it can be another soft tissue tumor itself. See, there are certain soft tissue tumors which comes in young age. They are very dangerous, round cell tumors. That
Yes,
gives
sir.
you entirely different picture to go ahead with what and what. So that is the reason you need to have an FNAC to know what exactly the cellularity. It is a mesenchymal, epithelial, or round cell, something like that. So FNAC will be ordered first, then MRI or CT scan based on the cellularity. Again, this you need to think again. Okay.
Yes, sir.
So
Yes.
FNAC, your preformed diagnosis will not help you. You should always have an open mind. This can be this can be this can be this. Since you are thinking in terms of desmond, that doesn't mean you require treatment. It may not be that. If it is something else, it's a different issue. So FNAC gives you a very important report. Other than spindle cells, if you have round cells at this is young age, you'll be in a big problem. Other things, because you will be missing many things. So FNAC, MRI has given the plane of the swelling, MRI says now. Sir, I'll just read out because the shortage of time. I'll just read out the MRI diagnosis. It's simple, sir. It is just avoiding the peritoneum. It is not going inside the peritoneum.
One question, Sahera.
Yes, sir.
Hello.
Yes, sir.
Will FNAC be conclusive in a
Sarcoma.
desmoid tumor or a soft tissue tumor? Because
sir.
many times you'll get a dense fibroblastic reaction for spindle cells. Okay, so will it be diagnostic? What is the percentage?
FNAC will alone not be a diagnostic, sir, because in FNAC we don't get adequate amount of tissue to further also get any other
Cell type,
markers.
cells.
Any role
Can
for
you differentiate between
Dr. Sahera?
benign and malignant?
Dr. Sahera,
Yes, sir.
any role for incisional biopsy?
Even true cut biopsy also you can advise.
What?
Ultrasound guided true cut biopsy to
Incisional
avoid the vascular
biopsy.
injury.
What is the
That
any role for incisional biopsy?
Yes, sir. We can go with incisional biopsy, sir. But when doing incisional biopsy, we have to be careful not to raise flaps, or we should be careful with the incisions taken, sir, to avoid any tumor
Of all the
tumor to be
biopsies,
spread.
of all the biopsy, FNAC, true cut, and incisional biopsy, which one is better? Which one is best?
True cut, sir. True cut biopsy, sir.
True cut biopsy. It has to be multiple true cut biopsies or incisional biopsy for any sarcomas.
sarcoma, yes.
Multiple true cut biopsies or incisional biopsy.
Why multiple true cut biopsy? I don't know actually. Any reason?
Not multiple true cuts, sir. Multiple course is probably trying to say.
No, it is true cut biopsy is fairly good in diagnosing the soft tissue sarcomas. Is there any need for multiple true cut biopsies? Less invasive than the incision biopsy.
If you have
this
a good,
might take.
no, sir. The core of the needle biopsy is more important here. If you get a good core, one single core is sufficient.
So that's what I think so.
Yes,
Okay,
sir.
true cut biopsy or core biopsy, that is core biopsy is accepted, Sahera.
Yes.
Okay. So if at all incision biopsy, you should be careful in including that Even true cut pass also to include in the next stage of excision.
Yes, sir.
If you plan, okay, to avoid
Tumor seeding, sir.
seedlings. Okay, that's okay. So, sir, can we move forward?
Yeah, just yes, please go ahead, sir. Please go ahead, sir.
Okay. So,
Where are we, sir? We are doing MRI or true cut here? Did we finish MRI and come back to true cut and then MRI?
yeah, relevant question, please.
Sahera, are you doing
Yes, sir.
MRI before or true cut before?
Sir, MRI to be done first, sir. Because any
Yes,
invasive
it can
procedure.
still it can bleed and planes can get distorted if you
Yes.
do a true cut biopsy or incision. No, that's accepted. That's the reason
Yeah.
we'll go for MRI of this case. Of course,
So,
makes
true
sense
cut
because
will
it's
distort the MRI picture. Okay.
Yes.
So, better if you have facility, go ahead with MRI first, then the true cut biopsy. MRI will fairly give you the idea of the plane, not only plane, the type of the tumor, whether it is benign or malignant, infiltration, edema, everything. Okay.
Yes, sir.
Then confirm it by the true cut. Cellular
Even more
subtype also you
safer,
can.
more safer in true cut biopsy nowadays. That is the ultrasound guided true cut biopsy they are doing because of avoiding hematoma, seedling. You can avoid and do true cut biopsy. That will be the
These big swelling, sir, and
because
anti-rupture.
sometimes in true cut biopsy it is a blind procedure. No, we may injure the vessels, all those. So you see which
If
side
it is a
ultrasound
smaller
guided.
one, we can target in that way. USG definitely help guiding it. It is a huge one. You have seen the picture, no? Huge anti-abdominal wall tumor.
okay. Can you
Okay,
display?
USG
Can you
definitely will
MRI
help
picture?
in guiding.
Sahera, display the MRI picture.
Yes.
Do you have MRI report or films?
Yes.
Can you zoom in?
Yes, sir.
Sir, we can zoom ourselves, sir, that one. Okay, Sarah. What is that you have here? Okay, Sarah, what is that you have in this case now? MRI, this thing, findings? Grossly, at least.
Can you read out the MRI
Sir,
findings?
sir, this is a T2 weighted image of MRI of abdomen pelvis, sir, taken, and it shows a mass in the in the left side of the abdomen, sir.
Probably the
Can
rectus,
yes,
left
sir.
rectus. It has involved left rectus, if I'm correct. Okay.
Yes, sir.
So you say
So
it is coming through,
as
arising
it
from
breach,
the muscle wall.
as it breached the peritoneum,
There is a gap.
No, sir. The posterior structures appear.
anywhere
No, sir.
infiltration to the skin,
No, sir.
well localized intramuscular. Is it?
Yes, sir.
Okay. In
Okay.
this case, did you do true cut biopsy before or MRI?
After MRI, we would go for true cut biopsy.
Okay,
You have
accepted.
not done true cut biopsy, no? Have you done?
This was taken before, sir.
So MRI was done. True cut is also done, right?
Yes, sir.
So what is the true cut needle or biopsy? This thing, histopathology.
It report shows features suggestive of benign spindle cell lesion, possibly desmoid tumors.
Okay.
So,
It's a benign lesion. Okay.
Yes, sir. Yes, sir.
So can we move towards treatment?
Sir, I have one question to candidate Dr. Sahera.
Yes, sir.
She has no other symptom, but do you think it can be associated with the syndrome? If so, any investigation, any other investigation? Suppose
So
you,
we would
yes,
we would advise for colonoscopy, sir, to rule out
exactly. Thank you.
polyps.
Thank you. Good.
Good.
Yes.
Good.
Thank you. Yes.
To rule out
Polyps, sir.
FAP.
Familial adenomatous polyposis.
Yeah. Good.
Go ahead. Next. Anything has been done to the patient?
No, sir, it's under investigation still.
Okay. So I think just quickly, Dr. Sahera, tell the plan of action, and probably examiners can wind up that with the proper, it's a very complicated reconstruction. So you have any plans, Dr. Sahera? Yes.
Sir, wide local excision, sir, followed by reconstruction of the defect, sir, with myocutaneous flap.
Why mycocutaneous flap? Why can't only mesh?
Sir, considering she's a female and she might want to conceive, sir, they might have a higher chance of incisional hernias.
No, why
Pardon?
to bring skin? Can it be only a muscle flap? That is mus dorsal flap. Can you do just with LD flap?
Dr.
Yes, sir.
Sahera.
Skin excision is not there.
Yes, sir.
Oh, only LD flap is sufficient.
So,
Yes, sir.
Sahera, you have shifted from general surgery to the straightly plastic surgery. Stay there so that you get more questions about the excisions first. Then we will start off a reconstruction. So, what is excision? What excision you like to do in this case and why? This is the first question you should answer now.
Yes, sir. Sir, wide local excision, sir, to achieve tumor-free margin, sir.
So this is a benign lesion. Why do you want to do wide local excision?
Sir, considering desmoid tumor, sir, it has high chances of local recurrence, sir.
Okay. So to avoid local recurrence, you would like to cover wider for excision, right?
How much wider you want to go?
How wide?
2 centimeters margin, adequate margin.
At least 2 centimeters.
At least
Yes,
2 centimeters would be adequate. But if the pathology says if you have constraints in this thing, if you are done with the margins which are less than 2, but the margins are non-negative, so probably that would be sufficient. In this case, you should not have any hesitation to take out this tumor without less than 2 centimeter margin in this case.
Yes, sir.
Can it become malignant any point of time?
No, sir. Desmoid tumors usually have extremely low chances of metastasis, sir.
It's not so okay. It has got high chance for local recurrence, no chance for metastasis. That is the reason the first and foremost aim is to resect as much as possible in order to prevent recurrence. Yes.
In this case, are you getting wide margin all around?
Yes, sir.
We'll try
Superiorly also you are getting?
Yes, sir. On examination, all the borders are well defined, sir. So
How far it is from the costal margin, superior border?
it's about 2 centimeters.
2 centimeters. So you are abutting the almost costal margin.
Yes,
Okay.
sir. Yes, sir.
If at all it recurs or chances of recurrence, What else you want to do?
We can consider radiotherapy, sir.
Pardon?
If
Radiotherapy, sir.
Radiotherapy. Okay.
even the surgery is the first choice, man.
Yes, sir.
Any other treatment?
Any recurrence is to be done surgery only.
Yes, sir.
Yes,
It
sir.
depends again. If it is a very huge, whatever it is, surgery would be the first choice here in this case. And if you are unable to do anything, then we are planning
Because
for
it is not malignant,
Yes, sir.
radiotherapy will not help.
multiple recurrences. There is chance, sir.
No, radiotherapy is also one of the modality of treatment, especially when you are unable to take the clear margin. So radiotherapy pre-operatively also can be done, used, though it is less sensitive, but that is, desmites are more sensitive to radiotherapy. What is about Guru?
No, sir. No, sir. Despite hardly multiple recurrences at the end stage, only if we cannot reconstruct all those things can come into the picture, then we'll think of as ablative procedure. Otherwise, no, sir. I think, yes, sir. PG should know any King's
Radiotherapy
classification.
has got role, and the any chemotherapy or any hormonal therapies?
So this is unusual
Hormonal-
sarcoma.
Hello?
Come on,
Yes,
sir.
sir.
Please talk.
Sir, hormonal therapy, we can consider this tamoxifen, sir, because some of the desmoid tumors have estrogen receptors and
Yeah.
they respond to selective estrogen receptor modulators.
So you can combine the tamoxifen also, and sometimes even there are multiple studies uh, about the imatinib also. They are using the imatinib, some chemotherapy drugs also. Okay. So
Yes,
it
sir.
also mainly in the cases where it is complete excision, three-dimensional excision is not possible. We can add all this armamentarium to the management.
Yes, sir.
Good evening, sir. I think it's a lot of time, sir. Now, I think we should try to wind up now. But the last question we have from Chairman, sir. Sahera, do you know anything about any King's classification for excision of sarcomas?
Yes, sir.
Yes. 1, 2, 3, 4.
It includes 3 tiers, sir. That is differentiation, mitosis, sir, and
That is not.
necrosis.
That is the grade of the tumor. What is in King's classifications regarding excision of sarcoma?
Nice.
So I asked that so that to give you more marks. You have well done, Dr. Sahera. So,
sir, I have a small question. She's done very well.
Madam.
Is it okay if I can ask?
Yeah, please, madam. Yes, you can ask.
Okay, now with a good excision, there will be definitely a large defect. So how she plans to reconstruct it?
That's what we have just discussed. Little more plastic reconstruction work. So I think, madam, you can quickly tell that answer so that we can take the second case, madam.
Basically, she needs a complete, literally, abdominal wall reconstruction, sir.
Exactly.
Depending on the extent of the defect, a 3D plan of reconstruction and as far as possible mobilization of the surrounding natural healthy tissue, and if required, maybe later on, if the significant loss is there, she can plan for a mesh also. But only thing that needs to be done in stage depending on the size.
Right. Yes.
Okay.
Yes. Okay. Thank you, madam.
Okay, thank you.
Gurubasavana, quickly you can summarize this and we can go to the second case. Quickly.
Yes, sir. Yes, sir.
Please.
Dr. Sahera, it was a nice presentation. Thank you very much. This was a soft tissue sarcoma as a diagnosis. Finally, pathologically, it was found to be a desmoid tumor. So, since it is a locally recurrent tumor, majority of the times it doesn't metastasize. So, we do not think it's a malignant tumor, but wide excision is the only option for to have complete clinical cure. If there is any deficiency in surgeries, then it will come back as a recurrence. So better avoid recurrence by doing first time itself the best surgery. Whatever reconstruction is possible, we can do it. We can wait sometimes if you are doubt that your margins are not this thing, then you can doubt, you can wait for final histopathology, then start reconstructing. This is another option we have. So I think we can wind up here, sir. I
Yeah.
think
Yeah,
we'll pass
thank you.
on to the next.
Yes,
Thank you,
yes.
sir. Thank you very much, sir.
Thank you, sir.
Good, good,
Thank
Sahera.
you. Thank you.
Good, good, good.
Thank you, sir.
Thank you.
Very
Okay.
good.
Yeah. Please unshare so that other candidate can start. Yes.
Good evening, one and all. I'll be presenting a case of peripheral vascular disease. My patient is a 58-year-old male, hailing from Mudanahalli with no formal education and is a farmer by occupation. The patient has come to the hospital with chief complaints of pain in the right lower limb since 6 months and complaints of blackish discoloration of right, third, and fourth toe since 2 months. The patient was apparently normal 6 months ago, noticed pain in the right calf and foot, which was insidious in onset, and it was brought upon by walking. The patient could walk a distance of 500 to 700 meters. Intermittent and cramping type of pain was felt. It aggravated on walking, forced the patient to stop and take break. The pain was relieved by taking rest and medication. The pain has progressed in the last 4 months. It was burning type. It was present in forefoot and was present even at rest, and it was not relieved even by medication. The patient also complains of blackish discoloration of tip of third toe since 2 months. It was insidious in onset. It gradually progressed to involve the whole of third and fourth toe. There's no history of foul-smelling discharge. There's no history of fever. No complaints of numbness or weakness in the lower limbs. No similar complaints in the other limbs. And the patient does not give history of chest pain, blackouts, blurring of vision, postprandial abdominal pain. My patient is a known case of diabetes mellitus since last 4 years and is on oral hypoglycemic drugs, and it is well controlled. There's no similar complaints in the past, and there's no previous history of surgeries or interventions in the past. There's no history of chronic illness in the family, and there are no similar complaints among the family members. The patient consumes mixed diet. His appetite is normal. His sleep is disturbed owing to pain. Bladder and bowel movements are regular. My patient is a chronic smoker. He smokes 10 BDs per day from last 20 years, and he has quit smoking 2 months ago. His smoking index is 200. Summarizing my case, here's a 58-year-old gentleman who's a known diabetic on oral hypoglycemic drugs. He's a chronic smoker who came with complaints of cramping and intermittent pain in the right leg and foot since 6 months. Initially appeared only on walking and could walk a distance of 500 to 700 meters, which has progressed in the last 4 months and is now present even at rest in the forefoot. It is continuous and burning type, and the patient has developed discoloration of right, third, and fourth toe since last 2 months.
Sir, examiners Dr. Ishwaraprasad sir, Kasa Somasekhar sir, and Dr. Shiva sir. Do you have anything?
Yeah. Later complete the examination.
Okay, sir. Okay, sir.
Going ahead with general physical examination, my patient is well built and nourished, conscious, cooperative, well oriented to person, place, and time, and his BMI is 23 kg per meter square. At the time of examination, the patient was afebrile. His blood pressure was 140 over 90 millimeters of mercury in the right arm in supine position. His pulse rate was 88 beats per minute, regular in rhythm, good volume, normal character, and the vessel wall was normal. His respiratory rate was 14 cycles per minute. There's no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and generalized edema. Coming to local regional examination, I have examined the patient in a well-lit room after informed consent and exposed from below umbilicus and in supine position. On inspection, the left lower limb is unremarkable. Right lower limb, all the toenails have ridges. The skin is dry and eczematous up to ankle. There's loss of hair noted up to distal 1/3 of right leg. Guttering of veins noted when the patient was asked to elevate the right lower limb. Venous refilling is prolonged. Visible muscle wasting is noted in the right leg. There's blackish, shriveled, mummified appearance of right, third, and fourth toe up to the base. Clear demarcation noted from the rest of the foot. There's no discharge. There's edema, which is confined up to the ankle joint. On palpation, right lower limb is colder up to the lower thigh when compared to the left side. Venous refilling time is prolonged. No crepitus at the gangrenous area, and muscle wasting is present in right leg. Peripheral pulsations from head to toe were checked, and on the right side, right lower limb, the peripheral pulsations distal to femoral artery were absent. On the left side, it was normal. The sensation and movement of right lower limb were normal except at the gangrenous area, and there are no enlarged inguinal lymph nodes. Coming to systemic examination, cardiovascular system, S1 and S2 heart sounds were heard and there was no murmur. Respiratory system, bilateral normal vesicular breath sounds were heard. Central nervous system, higher mental functions were intact and no sensory or motor deficits were noted. For abdomen, it was soft, non-tender, non-pulsatile. There was no pulsatile mass and no blowy heard. Summarizing my examination findings, 58-year-old gentleman, well built and nourished, with a BMI of 23 kg per meter square with stable vitals. Inspection of the right lower limb revealed dry gangrene of third and fourth toe up to the base without any superadded infection. And there were trophic changes up to the distal 1/3 of right leg, increased venous refilling time, absent peripheral pulsations distal to femoral artery in the right side, normal sensations and movement, no inguinal lymphadenopathy, and normal examination of the left lower limb.
Dr. Arora, there are two questions from Dr. Sunil Joshi, sir. Relieving factors of pain, sir has asked.
So initially, the patient said that the pain was relieved as soon as he took rest. But from past 4 months, there is no relief of pain even on medication.
And one more question, sir has asked radial artery details, rhythm, vessel wall, and so on.
So his pulse rate was 88 beats per minute. It was regular in rhythm. It was good volume. There was the vessel wall was normal, and the character was normal. There was no radio-radial delay. There was no radio-femoral delay.
Go to examiner, sir.
Yeah. What is your diagnosis?
Sir, after the clinical history and examination, my diagnosis is it's a case of chronic limb-threatening ischemia, right lower limb, due to atherosclerosis, with dry gangrene of right, third, and fourth toe, with diabetes mellitus, and the probable level of occlusion is femoral-popliteal.
Femoral-popliteal. So, how do you account for the wasting of the thigh if it is femoral-popliteal?
Wasting was mainly noted in the leg, sir.
Pardon?
So, in my case, the wasting was noted in the leg.
Half muscles.
No, you said wasting is there up to the thigh, no?
So, it was noted in the leg, sir.
Coldness is up to the thigh. Yeah,
Yes, sir. Yes, sir. When comparing the temperature, it was cold when compared to the left side, and it was up to the thigh.
Up to the thigh. How do you account if it is the femoral-popliteal occlusion?
Sir, since I could feel bilaterally, I could feel the femoral pulsation. The coldness can be explained by if there is a block just below the common femoral and above the popliteal.
But is it femoral-popliteal junction, no? You have given femoral-popliteal junction block, and femoral pulsations are very well felt.
Yes, sir.
Compared to the left side, it is 2+ you have written.
Yes, sir.
So, how do you get the symptoms or findings whenever there is a obstruction? Where do you get the symptoms or findings?
So the findings are always present one level distal to the level of the.
Yeah, if it is your femoropopliteal occlusion, that's what the reason I'm asking you. How do you account for the coldness in the
Lower
thigh?
part of thigh.
Is
So
it subjective or you want to give importance?
it could be subjective.
There is one specific question: is it superficial femoral artery or popliteal artery segment?
So the block could be at the superficial femoral artery.
Is that okay, sir? Sunil Joshi, sir?
Now, superficial femoral artery you are thinking of?
Yes, sir.
No, both occlusion or only superficial femoral artery?
So occlusion at the level of superficial femoral artery.
No, where will be the usually the block in atherosclerosis, if at all it is a femoral artery? Which artery is involved, whether superficial or deep? What is superficial femoral artery according to you?
So the part of common femoral that continues after the branching of profunda femoris.
Yeah, profunda femoris is a
Deep,
branch of
deep.
profunda. Is as superficial femoral. It is a misnomer. Okay. So femoral artery per se is the one which goes deep in the adductor canal. Am I right?
Yes, sir.
So according to you, femoropopliteal junction or femoral artery?
Yes, sir. Yes, sir.
So do you think even the superficial femoral is also involved in this case because of this finding?
Yes, sir.
Yeah, that is the another explanation. Okay, probably it has involved the profunda femoris also.
And profunda, yes.
Okay.
Yes.
So that's how we can substantiate if it is this finding is correct.
There is one more question in chat box. Why dry gangrene in diabetes? By our chairman, sir.
Sir, diabetes is associated with macrovascular as well as microvascular blocks. So as long as there is no superadded infection, a dry gangrene is a possibility in diabetes.
Yeah, good answer, because this is the common question which is asked also, and everyone talks about this. Diabetic gangrene is one of the things. Yes, significant atherosclerotic component, probably. Yes, that's the reason I asked this question.
Diabetes need not present always with the wet gangrene.
Wet gangrene, yes.
Exactly, that is the reason. Okay, so good to know. Yes.
One more question is, what is the blood supply of thigh?
So blood supply of thigh is from the profunda femoris and the superficial femoral artery.
Sunil Joshi, sir. Sir, you are muted. You are muted, sir. Sunil Joshi, sir.
Oh, sorry. Because profunda femoris is the artery which supplies the muscles of the thigh. So when there is a superficial femoral artery disease or the popliteal artery disease, the effects are seen distally in the toes, calf, and the toes for the foot. So profunda is usually spared. Superficial femoral artery is more commonly involved.
Yes, we'll go ahead. Yes.
So, sir, I would, with this diagnosis, I would like to go ahead with my
just for the other PGs actually. So why can't it be a late presentation of the Burgess disease?
So, for Burgess disease is a diagnosis of exclusion. There is Shionoya's criteria that has to be fulfilled for a case to be termed as Burgess disease. In my case, the patient is 58 years old. That is more than 45 years. Although he is a smoker, but there are also predisposing factors of atherosclerosis like diabetes mellitus and In my case, the involvement is in the femoral artery according to the history and clinical examination, whereas in Burgess it tends to be more infrapopliteal. And
Yeah,
there
that
are
is the
no
one. Okay. Say medium and small vessels
small
are
vessels.
involved. Okay. Here the
Yes.
femoral artery is quite large artery. Okay.
Yes, sir. Yes, sir.
Good.
And
So,
apart from
okay, proceed.
So my further plan of management is that to confirm the diagnosis, I would like to get imaging of the arterial tree. The first investigation that I would like to go ahead with is the arterial Doppler of bilateral lower limb. And since it's each case of peripheral vascular disease should be treated as a systemic disease itself, and therefore a holistic approach should be taken. I would like to get laboratory tests in the form of fasting lipid profile.
What is the cardiac risk for in this patient?
So there's a high chance of major adverse cardiac events.
What is the odds ratio?
So the
If you know,
with the increase in
how many times it is more prone when compared to normal patients for cardiovascular accidents?
I don't know the exact values.
Okay. Go ahead. Let's say more is nearly 6 to 7 times more proneness. That is the reason why you have said to holistic approach. That is exactly the answer. Okay. The reason is so cerebrovascular accidents, cardiac accidents are quite high.
Yes.
So we should not only concentrate on the peripheral vascular disease.
Yes.
Yeah. Aastha, there is one more question. You said bilateral Doppler. There is a question: why bilateral? Why not only affected?
Sir, since I am suspecting it because the cause could be atherosclerosis, there's a high chance that the other limb is also affected and the patient is just not symptomatic as yet.
Have you measured ABI in the left lower limb?
No, sir, I have not measured.
No, you should see. You said it is a holistic approach. Okay, limb threatening, you have to prevent left side also.
Yes.
Okay, so that is very important.
In simple way, atherosclerosis is a generalized disease. That's the reason that you have to evaluate for other limb also, other cardiac events, everything, even CV, what is called cerebrovascular accidents.
Yes.
And Doppler bilateral is not required. You can do only one leg to see what is happening. Just get basic idea. If you have to do something for him, you will have to do a CT angiogram or MR angiogram, which will give you the complete picture. It will include aorta, bilateral iliacs, all the vessels way down to the feet.
Okay.
So
one leg is enough.
Okay.
So if the ABI is threatening there in the left side, then we can ask for a bilateral Doppler, and as Sunil said, the CT angiography or MR angiography is more.
That will anyway include both the legs.
Yes.
If it is not critical at the moment, yeah.
Okay.
What is the Doppler report here? Doppler report here.
So in this case, there's diffuse atherosclerotic changes in the right lower limb. The right common femoral artery shows normal flow velocity with triphasic wave pattern, and there's a complete lumen occluding thrombus noted in right Dept. Right popliteal artery shows minimal flow with monophasic pattern. Right anterior tibial and posterior tibial show minimal flow with monophasic pattern, and right dorsalis pedis artery there's absent flow.
Left side?
The left side is normal. There is triphasic flow in all the arteries.
Okay. What is your plan of action? Sir, shall we move on to plan of action?
Yes, sir. Any other investigation done?
Yeah, I think.
Any other investigation?
I think. Since you asked, sir, any other? One carotid Doppler is also fine. Okay, it's important as a completion sake, and as a postgraduate, I'm not sure. I just might have missed. the auscultation, and this is the common question is asked in a patient with the suspected arterial disease. Where all you ausculted? Can you tell me, Dr. Aastha? Where all you
So
ausculted?
one had the abdominal aorta, sir.
Where exactly?
Just below the umbilicus, just above the umbilicus towards the left side.
So it's more or less in the epigastrium. Yes,
Epigastrium.
Next.
And we can also check for carotid
So
bruit.
carotid for a thrill or a bruit also important,
Bruit,
and
yes.
femoral artery also. Why femoral artery? Why?
So,
Oh, yes, please go ahead.
Sir, it is the most common area where occlusion.
No. What I'm trying to tell is why bilateral. See, it should be a policy. Wall thickening. See, already mentioned earlier, radial artery wall thickening and all. So the aortoiliac occlusions, always systolic. All these thrills and bruits are transmitted distally. You understand? If you find a auscultation and bruit over the femorals, probably you suspect the blocks are above. Okay,
yes.
right?
Yes.
So this is one of the things. So these are the common questions. Okay,
what are the common sites where these atherosclerotic lesions take place? Common sites.
At the areas of bifurcation of arteries,
Exactly.
and at SFA because it is under the adductor, it goes through the adductor canal.
Yes,
Now,
bifurcations
one
are
question.
huge.
Why adductor canal is more common involvement?
Yes.
Femoral artery, adductor canal.
Because it is relatively narrower area.
Narrow.
No.
Okay.
More fibrous area. Okay, inexpansible area.
Okay.
More chance. Inexpansible area. So more chance of it getting damaged by the flows continuously.
Okay.
Okay, that's why the reason femoral artery in adductor canal is more common.
Yes, sir.
There is one question here, whether you want to do CT angio or MR angio, and have you done any of these investigations in this case?
Sir, it is better to perform since the patient is diabetic, elderly, and I am suspecting there is a block at the femoropopliteal. It's better to get a MR angiogram because it helps to differentiate better between calcified vessel walls and the thrombus. But CT angiogram is always an option.
Not much difference as of MR angiogram and CT angiogram. Both will give you fairly good results.
Yes.
Okay, good idea, especially before surgeries. Okay.
This investigation is done. Have you done this?
No, sir. No, it's
What
not
is the
done.
role of DSA here?
Sir, in case we are planning for any reperfusion or intravascular interventions, only then we can go ahead with the DSA.
Sunil Joshi, sir, have you?
Yes, absolutely.
Advantage of CT
DSA,
angio over DSA.
With a Doppler, you have some idea. With a CT angio, you have some idea, or MR some angio. If the lesion is amenable to the vascular interventions, okay, then you can do on-table DSA and see whether you can keep all the materials along with you, plan it, and then you can do the intervention straight away along with. That is one thing. In extensively calcified vessels, you are not able to delineate the blood flow. That is another indication where you can see, because in DSA, because of the subtraction angiography, you eliminate all these calcific elements and you'll be able to see the flow much better. So these are the two indications of DSA in peripheral vascular disease.
Yes.
So what is your management?
How long is this segment? Oh no, we are not on the angio.
We have not got an angiogram.
But what is it on Doppler? Full of the superficial artery or only an adductor canal? Has he mentioned anything about the size or length of the blockage?
So the size and length has not been mentioned. Only the site of block has been mentioned.
What does he say? Oh, SFA.
SFA, sir.
SFA. So your lesion, whether it is stenosis, whether it is a long segment occlusion, will decide about how you want to plan the procedure. That is why an angiogram is essential in these cases.
Yes, sir.
Okay, so
There is
for
one
the
last
example,
Yeah. Aastha, show that next slide, because at a postgraduate level, we will be asking you the every investigation what you have written there and its relevance. Okay,
Yes.
sir, please take over.
Have you?
Please.
Do you want any other investigation?
So cardiac evaluation, and since he's a smoker,
Blood investigation. The lipid profile is also very important.
I've got to do.
Yeah, you're written. Okay. That is also one of the crucial predisposing factor. Okay.
Yes, yes.
So the question
echocardiogram?
which I wanted to ask her was number one, 13 grams per deciliter. What do you think the importance of this hemoglobin? First question.
So one thing, this is normal. In case it was elevated, it would be a
No,
risk factor.
You are talking about polycythemia. What I want to tell you, tissue perfusion, tissue perfusion. 13 is quite good. Total
Yes.
count 10,890. What does it tell you? This is the reason why I asked that question to you in the beginning. When I looked at the toes, what does it tell you? 10,890.
There is superadded infection.
So actually, there's a reason why I had put earlier the question in diabetics, and you are telling dry gangrene. Look at the sugar values there.
Yes, sir, it's uncontrolled.
And look at the glyco and why importance through creatinine. Just that's my questions. Then somebody will take over. Yes, please answer this.
So our random blood sugars in HbA1c suggest that it is poorly controlled diabetes mellitus. The importance of serum creatinine is that after the preliminary investigations, we would eventually go ahead with a CT angiogram. And
Excellent.
because it is contrast enhanced, we need baseline creatinine values.
So in a university exam, this is the most important thing which we are interested to ask you: interpretation and correlation of investigations. Okay, this is very important. The counts are high, so that's how lipids are high. That's where starts the lifestyle modification. Sir,
Yes,
Professor Kasa Somasekhar, please take over.
Yeah. This is more important, lifestyle modification. So how do you advise the patient or manage the patient?
So immediately, as the patient has come to us, we will counsel the patient about.
Modification?
So lifestyle modification. First, we would tell the patient about exercise, that is supervised exercise program therapy, in which we tell the patient about exercise for about 30 to 45 minutes, at least 3 times per week for a period of 12 weeks. Apart from that, we will also counsel the patient about strict cessation of smoking. Since the patient complains of pain, we will start the patient on analgesics. Since the patient, we know that there is a thrombus, we can start the patient on antiplatelets and anticoagulants according to the latest AHA 2024 guidelines. Since the lipid profile is deranged, I would like to start the patient on statins. And the blood sugars are uncontrolled, so anti-diabetics.
In this patient, you want to, if the lipid profile is normal, you want to start statins or not?
So we will still go ahead with the statins. So they help. Not only are they have anti-lipid action, but they also help in improvement of perfusion. And
especially when it is associated with diabetes, the statins have very useful statins. Okay.
yes.
It will
No,
hasten the
statins will help you in preventing her progress of disease.
Yes.
You don't know that. That is most important. That's the reason
Basically-
statins they apply.
Basically, it is a plaque stabilization. A plaque can be stable or unstable.
Yes.
When the complications happen, when the gangrene develops, it is usually a complicated plaque. Plaque is, if it is smooth, it doesn't cause any problems. If the plaque is ruptured or broken, and that is where the clotting happens, and the simple ischemia becomes critical ischemia. So you need some plaque stabilization effect of statins, even though the patient has got normal lipids.
Yes, sir.
Okay.
Okay, next.
So after this, we would. I would like to go ahead with further to delineate the block, how the anatomy and the velocity of the flow is. For that, I would like to go ahead with CT or MR angiography. In my case, either of them can be performed. Depending upon the findings of CT and MR angiography, we can take a decision of whether digital subtraction percutaneous angiography is required or not.
So, okay, distal, if there is a complete narrowing, what do you want to do? Distally, even DSC.
So there is no distal runoff. So are you saying that there is no distal runoff?
Yeah, if there is no distal runoff.
So in that case, we can
Probably, sir wants to.
It depends upon collaterals. You say that it all depends upon the collateral.
Collaterals, yes.
You have to conservative, mainly conservative management. Okay. Distal runoff, you can bypass it. Okay.
Yes.
They block.
Yes.
So there comes the basic things, the basic that questions, whatever, the endovascular surgery, and where nothing can be done. Your aim is for the symptom relief. This is the thing. I think that's what probably you want to drive there. So your answer should be that if you can't do any surgical procedure, you can't do any interventions, that whatever the radiological interventions, interventional radiology, so many things are there, but then what are the symptoms? What is your aim of treatment of this patient? You tell me now. Aim. What is your aim?
So first one should be reperfusion of the limb.
No, I want you to answer that control of diabetes and control of the gangrene if there is infection. Probably if the element of infection is there, do you think dry gangrene needs to be treated for amputation or disarticulation, or wet gangrene? This is the important question.
Wet gangrene has to be immediately treated.
Why not? Why?
Since he is diabetic, it might lead to systemic infection.
No, treated. What exactly you want to do?
So in case it is wet gangrene, I would like to go ahead with in this case, I would like to go ahead with a transmetatarsal amputation. But has it,
if it is
why transmetatarsal amputation?
What
the block is at the femoral artery. If you do only transmetatarsal amputation, will the stump survive?
So we can, after that, we can go ahead with the reperfusion again. Here the aim would be control the infection, but we must give.
Reperfusion is also a simple, it's also a very quick job. If you do angioplasty and stenting.
No, she is answering for the wet gangrene. It has to be damage control program like that, because you cannot have a curative surgery there. You have to control the infection. She is correct, because otherwise he may land up with a systemic infection like sepsis.
Yeah, that's correct. What type of surgery she wants to do? What type of surgery she wants to do if it is wet gangrene?
Tell Aastha, what is the lesion there?
So the third and fourth toe have been affected up to the base.
Yes.
If there is wet gangrene, it is safer to perform a transmetatarsal than to just do disarticulation.
Why you move to transmetatarsal?
Yes.
Not understood.
So I would like to go ahead with disarticulation of third and fourth toe.
Yes, I am trying to help you. Again, you are going there.
And drainage of any collection or pus in and around. Lay open.
Hello. It is a debridement first.
Damage control, what I said, it is a debridement only.
Infection, you have to control.
Yes.
Okay, then see, achieve for the line of demarcation.
Yes.
Then conservative the amputations.
Yes.
You have no choice of radically amputating the limb.
Mm.
Whatever may be the block, wherever may be the block, it is a conservative amputations.
Amputation. Exactly.
Yes.
This word
Yes.
should be there.
Yes.
Okay, you have to add with if there is a revascularization chances are there, you have to consider for the revascularization procedures
Revascularization.
to avoid future the complications and also heal the stumps.
Yes.
Revascularization can wait for a day or two, but the infection cannot. So first job is to get rid of the infection or drain
Yeah.
it or treat
That's
it.
what. After
And then for a
debridement and
vascular
achieving
vessel, if you think there is some
dry
problem.
gangrene,
Yes.
you have to control the infection first.
Yes.
So say many times the perception is if there is infection, just amputate radically. That should be avoided.
Yes.
Okay, so nowadays there is very little scope for radical amputations.
Yes.
Proper
Every
debridement
attempt
has
should be
to be
made to salvage. Every attempt should be made to salvage the limb.
yeah, salvage the limb. That's correct, sir. So in PVD, it is not the only limb we have to see. The message for all the PGs is holistic approach, as she said rightly. And another thing, control the comorbid diseases, and then revascularize the tissues after the conservative amputations.
Yes.
Dr. Anandravi, take some questions if at all is there.
Yes, sir.
Otherwise, we'll wind up within 2 to 3 minutes. We had actually 2 sessions just for informations of everyone, sir.
Yes. Almost we have
That
taken all the
last month. Exactly, we had actually Sunil Joshi himself moderated for the vascular case and both arterial disease, venous disease, but it's a good presentation. Just want to take some questions from there and then we'll wind up.
Almost we have cleared all the
Any
questions.
questions?
Sir. All the questions we have cleared from chat box.
Can I, sir?
An indication for amputation, sir has mentioned. Aastha, can you?
Yes, sir. Yes.
Indications for amputation.
So the indications of amputation include a dead limb, that is gangrene, deadly in case of malignancy, or a wet gangrene, and dead loss as in form of limb that cannot be reperfused or which has contracture or there is paralysis.
Sir has given a beautiful answer. Our chairman, Sir Rajgopal, sir. Deadly limb, dying limb, dangerous limb, and deformed useless limb.
See, don't
very easy to remember.
Paralyzed limb means somebody has a hemiplegia and all. Will you do that amputation? You don't do, no?
Yes, yes.
You don't do, correct? No?
Easy to remember and very good answer sir has given.
He is the author of the book, so he gives us like that.
I meant there is not those 2 toes removal. Say what happens is when our time, the vascular diseases, hardly any interventions possible. And Ballari, that way I remember so much of lumbar sympathectomy is being done. And also as a PG, I have done so many. So when nothing can be done, the option given was below amputation and some kind of a prosthesis like that. So that is a different issue now. So now it is like, very dangerous, especially clostridial gangrenes, correct? Extensive myonecrosis, extensive gangrene spreading, diabetic, septicemia. There's no other way. You have to save the limb, correct? And the deformed limb, so much patient can't at all. So, yeah, there's few things. That's from my side. Any other examiners, 1 minute, sir. Any other examiners want to add something, sir? Doctor?
Yeah.
Please,
okay. She has answered many of the questions. Okay.
Yes.
Shanai sir, can I put a word?
Yes, who is speaking, sir? Sorry, I can't
Dr.
see you.
Shafi sir, sir.
Because yeah, now I can see. You are not seen, sir.
No, ಅದು ಇಲ್ಲ ನಾನು ಮ್ಯಾಚ್ ನೋಡ್ತಾ ಇದ್ದೆ ಕ್ಲಾಸ್
Yes. Please, sir.
No, about this presentation, I think after a long time I have seen PG with so much of confident, clear presentation
Well,
of case. I think
well,
your HOD Ravi should be congratulated also because
well,
Ravi, no, you are HOD in him. Sir.
Yes, sir. Yes, sir.
I think you have met me in Bangalore NSG. You were there in
Uh,
IMA hall to send your boss.
Yes,
You came there.
yes,
No?
yes, sir. Yes,
Same
sir.
thing. It's do your good presentation and very
Thank you,
clear.
sir. Thank you,
Very
sir.
clear. That's what. Okay.
Thank
Good
you.
All the best.
Good presentation. I think we can wind up. I thank our office bearers, chairman, sir, secretary, and all the KCSA office bearers, one and all students and examiners also, and all the faculty, all who contributed for the success of this teaching program. I thank personally one and all, sir.
Sir, good representation also. About 75-80 people are already logged on. That is fine, sir. So, Dr. Sarvesh Rajan, please. And
Yes, sir.
Yes, you want to say few 1 or 2 lines before our secretary speaks.
Me, sir?
Yes, sir.
Sir, I'll finish with the vote of thanks, I think.
No,
Yes,
about
sir.
that, because today you are the main, the person who
Yes,
has
yes.
and Ravi. That's why Ravi spoke, Anandravi spoke now, just Gurubasavana. Then our
Absolutely, sir. A great number, great contributions from all. And I think that the many I think my professional colleagues and my teachers here from my department has opened up actually. Really, I have not seen them, but it is great seeing that Somasekhar sir and Dr. Shivaprasad sir here. Of course, many people contributed. Sunil has contributed a lot for vascular things. And of course, thank you. Thank you, one and all, for making this big crowd and big contributions, much discussions. Of course, went very much in depth. What is, I mean, as a postgraduates to think of, I think the postgraduates should not think very small because there is a lot of things happening because the questions you got today, probably they are bombarding ones. Of course, here teachers are very soft here, but not it won't be the same as in the real exams exactly. I wish all other students to study hard. That's all. No other shortcuts. Thank you, sir. Thank you for giving the opportunity.
secretary sir, please take over and finish.
Yes, sir. Yes, sir. Thank you, sir. It's a good, interesting case selection, excellent discussion of both the cases, guiding the PGs both for exam and also for their future careers. These things all happening because of our active and young chairman, one who travels throughout the state. Day before yesterday, he was in Bangalore. I was also there. Yesterday, he finished in the BMC one presentation and book release. Then he returned to Bangalore. And the same day, he went to Kanachur, where we are having MidCon, because we have already crossed 525. This is the almost highest registration in the MidCon, where we had around 480 in Mysore. In Shivamogga, we had few. And he's traveling all over the state, visiting the branches, encouraging the city branches to conduct programs also. I thank our chairman, Dr. Rajgopal sir. I thank our chairman-elect, Dr. Nas, who is preparing the PGs for their presentation of case presentation and poster presentations. Thank you, madam. I thank Dr. Immediate past President, Dr. Narayan Hepsur, who has joined today's program. Thank you, sir. I thank our today's moderators, Dr. Gurubasavana, Gouda, and Dr. Anandravi. And I thank the examiners, Dr. Kasa Somasekhar, Dr. Shivaprasad, Dr. Ishwaraprasad. So Ballari and Hassan made it a day today. And I thank and appreciate today's case presenters, Dr. Sahera from Ballari Medical College, Dr. Aastha Arora from Hassan Institute of Medical Science, and I thank Dr. Ravi, HOD of Hassan Medical College, for his presence and guidance for today's program. I thank Dr. Tejaswini Vallabha, Dr. Vidyadhar Kinal, Dr. Shafi, and all others. I can't name each and everybody because it's already 9:45. I thank one and all our EC members, GC members, and all the members and PGs. I thank one and all. Thank you all. Good night.